Welcome back to Only 10, where OT students come at you and tell you about the new techniques that we're learning about for the future practice of occupational therapy. Today, we're going to be talking about dry needling. This is something that's very new, a little controversial, so we're going to jump right into it. The first thing we're going to talk about is the technique and what dry needling is. Dry needling is where the needle gets put into the trigger point of the muscle. And a trigger point is usually just a piece of skeletal muscle that is getting really hard. And you can feel it on yourself. So if you're watching this, go ahead and start feeling your thighs or feeling your arms, just anywhere. And you can feel little bumps where you can feel a little bit of pain, a little bit of tenderness right there over that area. That's where you're going to put a dry needle. And then this technique is usually performed by physical therapists because it is within their scope of practice. Currently not within our occupational therapy scope of practice, but we still need to be informed together. So we're going to show you a quick little demonstration video on what dry needling is. Let me just go ahead and share my screen. Okay.
Perform ulnar deviation. Maintain a clean technique by using gloves and performing an alcohol wipe down.
Do a full wipe down.
Identify the area of the wrist extensors to be treated and bracket the tissue. Insert the needle directly into the muscles of the posterior forearm. The technique is repeated for each wrist extensor.
And then at the very, very end, another fun thing that you can do is attach electrodes, like a TENS unit, and then you could feel the muscle jump.
Perform pistoning or leave the needle in situ for electrical stimulation.
Perfect. Beth?
So let's just talk about the procedure a little bit and how this is applied in regular practice. So a typical session is when the needles are inserted into these trigger points. And then a twitch will respond when you put that needle in. So you're going to be having to feel through the needle or see it visibly if you can, depending on the size of the twitch. And then the needle is moved, or needles are put in other areas down until all the trigger points are found. And then so normally a dry needling is used to induce a stretch of a contracted muscle. And then it'll help with the overlapping of the actin and myosin filaments in that muscle to get the kind of reaction that you want. And then also, as everything is different, needle sizes are different. So depending on the area or the muscle, it's going to depend on the needle size you're going to use. So normal, smaller size needles you're going to use for smaller muscles, just to make sure you're pinpointing exactly where you want to pinpoint. Let's talk a little bit about the difference between dry needling and acupuncture, because there is a big difference that has been found in the research and historically.
Yeah, absolutely. And not many people know the difference.
So dry needling, you're actually going into the muscle, and then acupuncture, it's a traditional holistic kind of medicine where you're just hitting underneath that skin surface, and it's working on like chi and other things, not just muscle movement and working on that muscle rehabilitation.
Absolutely. Very good. Well, when you're looking at specific populations that you can use dry needling with, since it is a little bit more experimental, they are staying away from working with children at this time. But usually it's used with populations such as CP, anybody who has cervical pain, anybody who has any type of myofascial pain or myofascial pain syndrome, anybody with any type of spasticity, and strokes are primarily the population that's used for. And that's what we focused on in a lot of our research, was strokes and spasticity. And when you put in the needle, it helps improve range of motion, decrease spasticity, and decrease pain. So that is the main goal of dry needling. And that's why strokes are looked at the most. And spasticity is one of the most common symptoms of open-motor neuron syndrome. And also spasticity is common in 60% of strokes. So this is a very large population that this can be used with. And then one thing I found really interesting, we talk a lot about in OT school, is the bow bath technique. If you use dry needling and the bow bath technique interchangeably, they actually work a whole lot better. So if you're using those two together, you're going to see greater results in decreased spasticity and increased range of motion.
Pretty awesome.
Yeah, I know. So cool.
But like anything that has some problems and some populations you would not use it on, so does dry needling. So if you've got a patient with a needle phobia, you probably won't be able to do dry needling on them. Even yourself, if you can't stand needles, you're not going to want to be doing dry needling.
Like my girl over here.
So those are some things you got to have like full understanding from the patient about what's going to be happening, because you're breaking that skin barrier and you're literally putting a needle into the muscle. So advanced training is going to be needed as well. You've got to have patient history. Abnormal bleeding responses are going to be one of the bigger things you're going to be wondering about or needing to know about, because again, you're going to be breaking that skin barrier. If they're on blood thinners, that's going to be a concern and something you're not going to want to do dry needling with. During medical emergencies, obviously you're going to want to stop whatever you're doing. Any area with lymphedema or potential for lymphedema. So if they've had a mastectomy and they're not allowed to carry heavy weights on one side or do anything, get needle blood drawn, you're not going to want to do dry needling in those areas either. Immune people, like if you have an autoimmune disease or your immune system's compromised, you're going to want to be cautious with using that as well. Diabetes, pregnancy, and then allergies to latex. I mean, it's because you got to wear gloves when you're doing this mostly for the most part. If they have epilepsy, you're going to really want to stay away from dry needling. And if they're at an increased risk of infection, you're probably going to want to stay away from it too, just because you are breaking that skin barrier and there's higher potential even if you are rubbing the area down and using those clean needles. You just got to be really careful about this, because it's not like putting on a heat pack. You're going into the muscle and you want to be extra cautious with that.
And make sure that you always glove up when you are doing dry needling, because that is going to be one of the biggest things and can cause serious infections if you don't.
It's going to protect you as well as your client. So
exactly. Now, anticipated results, as we've talked about, a lot of it is decreasing that spasticity. And a lot of our research shows that there's improvement in decreased spasticity and then actually alpha motor neuron excitability. So I thought that was really cool, just the science behind it. And then also with dry needling, if you use it at one session in one pinpointed amount of time and you do that over and over and over instead of like one long session, you're actually shown to get more results. So that is something that's really cool as well.
So again, like we said, this is really an emerging practice of OT. It's not something in our scope right now. I know people are, there's some advocacy and there's some hesitation towards it. And again, mostly physical therapy is doing it. But there's not currently enough research to support our role using this right now, even though there is research being done about spasticity, range of motion, and the benefits. But again, if it's added, it's going to be considered a PAM, so a physical agent modality. And those are always up to the discretion of the therapist and the considerable amount of training you want to do. So it depends on your setting. If you're in a school-based setting, you're not going to be dry needling, but if you're in those outpatient settings, you'll probably be dry needling. And those are patients normally who've been past a certain point in their recovery and are able to handle that kind of intervention.
Absolutely.
And so we talked a lot about the stroke population, but there has been some research on different conditions like cerebral palsy. One of the big things about that is it's mostly in children right now, and the adult population hasn't had that much research. But then again, you want to be extra cautious because you're working with children. And then you've got brain injury. Again, you want to be cautious, and especially since you want to consider the cognitive level of your clients as well. MS, multiple sclerosis, and ALS or Lou Gehrig's disease. Those have been researched, but there's not enough research to say that dry needling is gold standard in some of these things.
Absolutely. And on your handout that you received, you do have all of our references. So if you have any questions, feel free to reach back out to us. Only 10. Bye.